And we had presentation from Ajay, that fortunately also we have here. Elena Bob from the tuberculosis for Elena Bob, histoplasmosis from Alejandro Pascualotto, cryptococcosis for Joe Jarvis, and HIV mortality by Veronica Martin. Ajay, and I will try not to enter too much in this because he can comment that in the panel, provide the global context of advanced HIV disease, one systematic review they are doing in the cost of hospital admissions, and in particular, this is a review of the previous systematic review, an update of the previous systematic review, and we continue seeing a high rate of death among patients that are admitted with HIV, 17%, and this increased to 55% when we are talking about intensive care unit cohorts. The reason for admission continue being age-related in 42% of the case, 19% tuberculosis, and 26% of bacterial infection. There is a big need to describe a little more what are these bacterial infection situation, because many of the patients are labeled as sepsis, and sometimes the diagnosis is not very clear. Non-communicable diseases that in countries that are doing the thing well, you should start seeing to reduce the mortality for AIDS and start to see admissions and problems related to non-communicable diseases, as Shanti mentioned. It's still very low in the majority of low middle-income countries. Ajay will present in the panel what the WHO is doing, but a new guideline will came the next year, and there will be a lot of information on Kaposi, on TB, new diagnostic, or recommendation for management in the hospital and post-hospital care. Just a note, it's a new rapid communication from WHO for facilitate, streamline the diagnosis of HIV people for tuberculosis. So now it's a recommendation to use in parallel the expert and the LAM for patients with advanced HIV disease. No more this classification 100, 200 admitted in the hospital or not. So all severely ill or with less than 200 CD4 can directly do parallel testing with expert and LAM. Elena Bob focused her presentation in the lesson learned from countries in scaling up the preventive treatment for tuberculosis, and we have a lot of work to do because we say we will achieve 95% of the new HIV patients receiving prophylaxis once tuberculosis is ruled out, and we are very far from this figure. Good examples like Zimbabwe that increased 10 times the number of people receiving prophylaxis. So the real issue here is to plan very well, to have only one option and not a plethora of different options, because this is confusing for the providers, to try to do some pilot study and then scaling up and do the monitoring, how this is advancing. She presented more lessons learned, like coordination is critical, the update of national recommendation, to have a training for healthcare workers to include TPT, and obviously to have access to 3HP. And the price, fortunately, the price has been reduced, so it's something that can be very easy to acquire. Still, we have a lot of work to do with a very few patients, new diagnosis patients started TPT. Dr. Pascualotto presented the issue, the situation and screening diagnosis of histoplasmosis. As you know, the histoplasmosis can be confused with tuberculosis in many instances, in particular when there is a pulmonary symptom. There is an overlapping of different situations, but both diseases can affect or have digestive syndromes or lymphoadenopathies, but histoplasmosis is more, the skin lesions are more frequent in histoplasmosis. So if you have patients with skin lesion with advanced HIV disease, think about histoplasmosis. The best way to do the diagnosis can be the histopathological examination, but you need to be very well trained. But you have the antigen that is very easy. You have ELISA, you have rapid test, and it's more specific and more sensitive than many other diagnostic tests like antibodies or PCR, even PCR. The treatment, liposomal amphotericin and itraconazole, is necessary that each country has if you treat histoplasmosis with. Joe Jarvis presented the new evidence on the management of cryptococcal disease. Here, the concept is the crypto antigen save lives. You cannot wait to the patient to have symptoms. You need to screen any patient with less than 200 CD4 for crypto antigen, and you will reduce the mortality in 12% in this case. The management of the cryptococcosis is very complex, and you cannot use monotherapy. Here you have the failure rate with fluconazole, different doses, between 50% to 96% of failure. So you need to treat those patients with amphotericin, liposomal amphotericin, 5-fluoxetosine, and fluconazole. You know that dexosocolato amphotericin can be used because it's cheaper, but has many problems and very difficulties. So we need to have access to liposomal amphotericin, and Joe Jarvis did this beautiful trial, and he compared the amphotericin, the desoxicolato, with only one dose of liposomal amphotericin, high dose, all together, only one day. And they recruited 800 patients from different countries, and they could demonstrate that the efficacy was a little better, and the adverse event was much better when they received liposomal amphotericin only one single dose. And for this very good result, they were very quick, very good in putting or implementing this new result in the WHO guideline, and then to start the implementation in the countries. And now, on those countries, liposomal amphotericin, single dose, more fluoxetosine and fluconazole is the standard of treatment. Veronica told us why the mortality need to be measured. We don't have data on mortality in the region. We don't know what are the reasons of death in the Caribbean because we are not collecting this systematically. And this is very variable. And this variability, we know that is because of underreporting. We know that it's very bad quality of the register. There is no concordance with the different registries. So we are working in a protocol to standardize the analysis of cause of death. But what she did is to to have a literature review, call a panel of experts and do some meeting to understand how to analyze initially AIDS mortality, because the idea was to prevent HIV deaths, okay? So she worked with AIDS mortality. She realized that there are other causes of death that are related to HIV, even if it's not AIDS, and then she defined what is HIV-related and preventable mortality in this consensus. Doing that, she had to triangulate different databases in UK. Fortunately, they have a lot of database to combine. They had to do some coding of the causes of death because the coding, as you know, is very complicated and not always represent what we want to see. And then they started to analyze the reason and analyze the cause of death and define what to do, what to change to improve the system. They could identify that in the UK, different from the Latin America, 16% of the deaths are related to AIDS. And still, she could identify 13% of those that could have been prevented. So there is something that we can do similarly here. So what we have learned in the region We know that a lot of follow-up is contributing more to advanced HIV disease than late diagnosis, because in some countries, like in Trinidad, 70% of the late diagnosis are patients that are disengaged to care. If we screen systematically those patients, we will have more than 30% of them with some opportunistic infection, being tuberculosis, histoplasmosis, or cryptococcosis, the more frequent. And not because are the more frequent, it's because we have the tool for do that very quickly now. We don't have tool for other opportunistic infection. The information, I say, is very limited about the cause of death, and in many countries, we don't have the antigen, we don't have liposomal amphotericin, we don't have 5-fluocytosine, right? The hand who has 5-fluocytosine to treat cryptococcosis in the country. That is critical for improve the survival. PAHO is proposing this project that is try to test everybody that arrives with a new HIV case or re-engage that has symptoms or that is having a less than 200 CD4. Let's to do in the same day histoplasmosis, crypto, and tuberculosis screening and try to reduce the mortality for those diseases. For this reason, we asked UNITAID for a grant. Unfortunately, we could got this new project that has 5 outputs. The project will enable us to support the strengthening of information system, to analyze with different countries what is the preventable mortality, and do also and support countries' national AIDS program in do implementation research for reduce the mortality of HIV people. Some of the information system strengthening that we want to achieve is that each clinic has some dashboard that can allow them to track patients that are disengaged of care and be able to put some action to re-engage those people more quickly. Also, we can create cascade of care for people with a specific infection like with tuberculosis. The second output is to develop a mapping in different countries about what is necessary to treat and to diagnose, what are the status of different tests and medicine in each country, and work with countries to start introducing or accelerating the introduction of a specific medicine like 5-fluocytosine, even if we need to do some catalytic donation to stimulate this if the country commit to continue buying. This is the list of the priority products that PAHO include the VCTech rapid test that measure less than 200, the ELISA antigens, the antigen for histoplasmosis, the ELISA or the lateral flow assay, both for crypto or for histo, the expert, and the treatment, amphotericin liposomal, 5-fluocytosine, itraconazole, that some countries doesn't have. The third output is to align the guidelines and the national strategic plan so we can support countries that are planning to review the national strategic plan, hopefully integrated with TB, HIV, hepatitis, and STI, and also some guidance like opportunistic infection. This is the different number of guidance or guidelines or norms that each country has, and we can try to support the update. Also, we need to create demand, to create demand. So we can support countries to work with partners, with CCOs and civil society to explore what is the needs of this population to be involved in the prevention of HIV deaths. Yeah? Look for those that are disengaged. Work with the community to inform about the risk of no seeking care when you have fever, etc. And finally, the last product is to develop a partnership, a network of experts, and support meeting, which is this meeting is part of this product. So if your national AIDS program has some specific needs that can be requested to reduce the HIV deaths in the country, and if you have a clear feeling that doing that, you will really have an impact, you can contact the PAHO office, and please copy Sandra, to discuss this idea with PAHO to try to support some of those initiatives. This is my presentation. Thank you very much, in particular to the team.